Okay, so I'm recording the session. So the exam number 2 includes all these 4 different topics, and all of them cardiovascular, by the way. So all of them within the same system of what is called cardiovascular. So the dysrhythmia, the CHF failure, the vascular problems, the acute coronary syndromes or ACS, all belong to the same uh, system. So the dysrhythmias, which begins with the different types of dysrhythmias, and as we said that in class, we are going to cover part of the dysrhythmias this semester, and then the I would say the more advanced dysrhythmias will be covered in 441 adult L3. So the dysrhythmia begins when, or would start or occur when there is a disruption of the conduction system, the conductive or the electrical conductive system in the within the heart. When it's disrupted, that's what is going, to what is called, result in or produce or lead to what is called dysrhythmia. And the conduction system in the heart begins with the SA node. So the SA node is going to fire the impulse, to innervate or to stimulate the atria and ventricles to be innervated, and then it cause, result in atrial click or contraction of the blood to be emptied into the ventricles. So the impulse then travels down to the AV node and then to the rest of the conduction system, Purkinje fibers, and then the bundle of His. So all of the electrical conductive system or this conduction system will be number 1, which is the phase 1 prior to the contraction. So first we need like electrical conductivity before we see any mechanical contraction or mechanical activity, like so atrial click or atrial contraction, which comes after the electrical conductivity. Same thing with the ventricles. Ventricles is going to contract and empty the blood, either the left ventricle into the systemic circulation or right ventricle into the lungs. Before this contraction, physical, mechanical contraction and emptying of the blood, that should be coming after the electrical conductivity. So conduction system, electrical conductivity, and then the mechanical outcome or mechanical click or mechanical contraction. So this is the 2 phases of the heart when it comes to cardiac cycle. It's electricity plus activity, or which is the contraction or mechanical activity. So anytime whenever there is a disruptive element of the or element of disruption in the conduction system, you will find out that from the EKG that is distorted, that is abnormal, and then that will kind of result in also other cardiac issues, which will be presented in terms of like problems, cardiovascular manifestations and symptoms. So before we get to the content, let's just focus for a few minutes on the EKG and see how we're going to analyze the EKG. The ECG analysis to have a sorry. I'm not sure. I lost the slide somewhere. Okay. So the EKG or ECG analysis, it requires some type of the systematic analysis or methodology. Systematic methodological analysis or interpretation of the EKG requires that these are the three main steps or three main questions we are going to, or areas in which we are going to ask ourselves few questions. And if you try to comprehend this slide, you'll be able to analyze any EKG. So for the so we're going to focus on 3 things: P wave, PR interval, and the QRS. That's all we're trying to get, out of this EKG analysis for adult L2. So for the P wave, ask yourself all these questions. You will end up with answers that will lead to either we have a normal sinus rhythm or there is some type of dysrhythmia. And what we would be able to also know what kind of dysrhythmia is that. Same thing for the PR interval. Try to analyze that as well by asking yourself 3 questions. Same thing for QRS. If you ask, yourself 3 questions also, which is basically it's all about the morphology, which is the how the wave is presented, and almost all these questions has to do with the presentation of the wave or the of that complex or the wave, and also the interval, the length, and the which is the time traveled that wave has traveled or the impulse has traveled from one A point to B point. So it's all about the morphology and the time of travel. So the all these questions, once you ask yourself these questions and you'll be able to analyze, we'll get to some of these, EKG strips and try to analyze that. So we have two main length or intervals. We would like to make sure that you know them by heart. The first one is PR interval, PI, PRI, or PR interval, and which is supposed to be between 3 to 5 small boxes. We said that each small box is 0.04 seconds. If you multiply that by 3, that's 0.12. And the 5 small boxes, which is one large box, which is the 0.2 seconds. So the PR interval, which starts from right here, from the beginning of the P wave, right at the beginning of the Q, right where is the Q is going to start, that's all of this is called the PRI. So that's supposed to be not to exceed 5 small boxes, which is equivalent to 1 large box. When we say 5 small boxes, it's equivalent to that exact same length of 1 large box. For the QRS, if you have noticed that the QRS is way shorter than the PRI. PRI is supposed to be not to exceed 5 small boxes. However, the QRS not to exceed, it starts can be only 1 small box. Can be the least 1 small box, 0.04. It should not exceed 0.12. Actually, you can change that to 2 to be like 3 small boxes. So it should be between 1 and 3 small boxes. So QRS should look more narrower than and shorter than the PRI. So these are the two main or major length that you have to master. The PRI between 3 to 5 small boxes and the QRS between 1 to 3 small boxes. So the heart rate to be calculated from the EKG, we have 2 methodologies. The first one is to count cycles. See how this book follows the cycles, the cardiac cycles, not our waves. So when you count, you say 1, 2, 3, 4, 5, 6, 7, 8. And we said that, the strip length should not exceed the 30 boxes, which is equivalent to the 6-second strip. So you have to count from the beginning of the first box and all the way has to be like 30 boxes and stop. So this is your area of counting the R waves or the R cycles and times 10. So limit yourself to these 2 limits or markings. So you have to do two dots here about the beginning of the end of the 6-second strip, which is equivalent to 30 boxes. And then you will find out how many cycles or R cycles, like 1, 2, and then you keep going, are counting these cycles, and then you multiply by 10. So I know that some had said about the R waves times 10, but most textbooks are going with cycles times 10. So this book, belong to that theory of cycles, right? Not R waves times 10. So that will be your heart rate. Now, another method, which is the 300, which is you are going to count the large boxes. Let's take any R wave to R wave, and in assumption that the EKG strip or the rhythm is regular. So when the rhythm is regular, then we're going to count the large boxes from R wave to R wave. So we have from this R wave to that R wave, that one is 1, 2, 3 point, almost like 3.5, 3.5 large boxes. Count here, 1, 2, 3, also 3.5, 3.5. So we are going to divide the 300 over the number of the large boxes between from R to R, from R wave to R wave. If patients from R wave to R wave is one large box, is going to be 300 over 1, which is 300. So the heart rate for a heart rate of patient's heart, in which that the R wave to R wave is one large box, it's going to be like, you'll see like large R wave, R wave, R wave for every single one large box. In other words, that the 300 over 1 equals 300, so that patient heart rate is going to be 300. Patient heart rate of two large boxes, if the R wave falls in right here, then this patient will be 300 over 2, heart rate is 150. Three large boxes, exactly three large boxes, this R wave falls in right at the beginning of the large box, then 300 over 3, then the heart rate is 100. So all you have to do is just get that 300 number and divide it over that number of the large boxes from R wave to R wave. Medications. I know that I did not talk a lot or maybe discussed or went over this stuff in like comprehensively or intensively in lectures, but I would recommend that we go over at least these medications to at least understand the mechanism of action, how these meds are going to treat dysrhythmias. And we talk a lot about digoxin, atropine, maybe dopamine, dobutamine. At some point, we talk about some of these other medications, vasopressin maybe, but go over these medications and try to comprehend and maybe master all these meds in terms of indications, side effects, implications. So briefly just go over these medications and understand the utility of these meds and the usage of these meds and fixing and treating and managing the patients with dysrhythmias, different types of dysrhythmias. So if you're going to analyze these EKG strips, look at the first one here. So, I provided you with some, the answers, but this is the analysis supposed to start from. If you look at this QRS and the rest of the QRSs, and this one, and then the last one as well. I was just looking at the top one. The bottom one is same thing, but it's just a different lead. This lead, we said that lead 2 is the most representation or the most the lead that is going to present the best representation of the EKG, and for many reasons that lead 2 is the best, right? So that's why most people are liking be textbooks and even telemetry units and cardiovascular people or surgeons, and they belong or believe that the lead 2 is the best. So because that's going to provide the best representation of the other EKG or the other leads. So instead of presenting on the monitor the 12 leads, we can just have one running lead, which is lead 1, which is lead 2, one lead, which is lead 2, number 2, but it's going to be a good representation of the rest of the leads. So the QRS, right, the first one looks abnormal. It doesn't look like the other QRSs. Same thing for this one. And the first one here, the abnormal one, is going to be very similar to this one in the middle, as well as the last one. So as we analyze, we're going to look at P wave. What is P wave? I don't see a P wave here. I see a P wave right there for the second one, and then a QRS, and then we have a P wave, T wave, P, QRS, and then P, QRS, T, and P. So everything, this cycle is normal. We have like 4 normal cycles, but the first one and the middle one here, it's abnormal. So this is a ectopic cell from the ventricle that has kind of erupted or created the dysrhythmia, which is going to be called PVC, premature ventricular contraction. So the ventricles, one of the cells in the ventricles decided to pace the heart and fire the impulse and create the PVC. Now, the PVC is obvious that it's more or it's much easier than the PAC. The PAC, you will find that the PAC, the QRSs are within normal, within range, or they are normal and they are similar to the QRS to the other QRSs. So the QRS on the PAC is very normal, very similar to the QRSs, the rest of the QRSs. But the problem is always with the PACs that the cycle as a whole comes premature. But you can easily tell here this is a PVC, and since that all these PVCs are similar, the same, looks like they are all coming from the same ectopic foci. They are unifocal PVC. So the answer to this will be it's a sinus rhythm, but it's a unifocal PVC. So this one is, as you analyze it, you have a PQRS, and if this is a 6-second strip, the whole thing is 30 boxes. I believe it's a 6-second strip. So then you're going to count cycles. As you count cycles, the rate is going to be very close to 40. I know it's if you use cycles, you're going to say that it's 1, 2, 3 times 10, that's 30. You can say that's 30. According to this methodology, it's 30. But if you are going to use the 300 method, then we have 1, 2, 3, 4, 5, 6 point, almost like 6.2. If let's say that, that's 6.5, let's say 6.5 and 300 over 6.5, you'll find that I know that the first cycle or the first cardiac cycle, it's kind of missed. The whole thing is missed. Completely had been discounted, like not being counted within the R wave to R wave or cycles. But we can use. So according to the R wave to R wave methodology, it's 30 heart rate is 30, but you can also use that 300 to confirm that number. So you can divide the 300 over 6.5 and you find out the answer to confirm your the answer from the first methodology. And with the VTAC, you definitely are going to see a QRS that is completely distorted. There is no P wave, and that is how the ventricular contraction, I'm saying ventricular tachycardia will look in terms of that will be depends because we have two different scenarios with the VTAC. The VTAC, the defibrillation is automatically going to defibrillate the patient. Defib. VFib, you have to defibrillate. You have to defib. With the VTAC, you have two scenarios. You have to find out from your assessment. You have to go ahead and assess the patient and see what's going on, and then you call the code. And if the patient is pulseless, there's no pulse, you can't feel the pulse, no way they can find the pulse, then there is going to be pulseless VTAC. And the pulseless VTAC, according to the ACLS algorithm, which is Advanced Cardiac Life Support algorithm, you are going to treat the patient as if the patient is a VFib, which is to defibrillation. However, that with the VTAC, you still have to do a few things before you go and defibrillate the patient with the pulse with VTAC, like patient with VTAC, but still you can feel the pulse. If you can feel the pulse, that's a different scenario. But if you can't, this pulseless VTAC, that is be treated with as a patient as a VFib, and then it will be defibrillation in that case. And we'll go over this also in more details in adult L3 as well. This is anytime you'll find a QRS is all of them, not necessarily that R wave to R wave is going to be consistent in terms of distance, because sometimes patients will be presented or the EKG will be presented with more than one dysrhythmia, like multiple dysrhythmias in one strip, EKG strip. For example, this one this is an AFib. All of these are small tiny P waves. You can count them. There is no way you can count these P waves. Automatically, that's an AFib. The QRSs, they are identical, but the problem is that with the QRSs, they are coming some of them, they will be coming prematurely, which is the PAC, premature atrial contraction, because the P wave came prematurely. The QRS kind of followed that P wave, the distorted P wave. So the QRS kind of blindly following the distorted P wave. That's a PAC, premature atrial contraction. So in this case, we have a AFib plus you can see plus multiple PACs. Like this is a PAC. This came in prematurely because look at this, 1, 2, 2.5 boxes, and then we have 1, 2, 3, almost like 4 large boxes. And this is the pause we talk about after the PAC. Then back to normal. This is the normal 1 to 3.5. This is the intrinsic natural normal R wave to R wave, the length. And then we have another PAC, another PAC. So these are multiple PACs plus atrial fibrillation. And the last one here, we have a patient with
Professor,
yes,
I have a question.
sure.
So, how many boxes are supposed to be between, like for example, if it's like a normal sinus rhythm, how many boxes are supposed to be in between
Well,
the
if
one
your
R
heart,
and
yeah,
another R?
good question. There is no one specific number for to say in normal. The number range, remember that the range of normal heart rate is 60, 100, right? 60 to 100.
Yes.
So, so, so it's supposed to be between, if we say how many boxes, we will say like 300 over 5, right? 300 over 5. So it should be between 5 large boxes to be 60. The heart rate is 60, supposed to be 5 large boxes. It can go up to, um, or I mean, less than 5 boxes, which is going to be 3, right? So from
Hmm.
3 to 5. From 3, if I'm going to say that, how how many boxes or large boxes supposed to be from R wave to R wave to be within range? Within range is 60 to 100 heart rate.
Hmm.
Supposed to be between 3, like 5 boxes up to 3 boxes. Like the 5 boxes equivalent to the 60, and the 3 boxes equivalent to 100. Make sense?
Yes.
Because if you multiply the 300 over 3, that's 100,
Hmm.
and 300 over 5 over 5, 60.
Okay.
So that's the range of 60 to 100. That's 3 and 5 large boxes. So within that range, there's going to be like normal.
Okay. Thank you.
Good? Yeah, you're welcome. So the large one here is that we are looking at the large EKG strip. So we have a P wave, QRS, and then we have QRS that is completely different from the rest of the previous two cycles here. So this is completely different. Morphology, amplitude, everything. So same thing here. We have now PQRS, T wave, PQRS, and then I don't see a T wave, see right? Another one similar to the previous one here. So this is another, and then resumes the normal intrinsic natural cycles resume PQRS T, PQRS T, or there's no T after because we have a QRS. So I'm sorry, PVC. So we have 1, 2, 3 PVCs. So we have this is called trigeminal because it is consistent that we have 2 normal cycles and then 1 PVC. Two normal intrinsic natural normal cycles and then PVC. 2 normal cycles and PVC. This is a trigeminal. The bigeminal would be 1 normal, good one, and then we have 1 pathologic or PVC, not good. So we have 1 good, normal, intrinsic, natural, and then PVC, normal PVC. That is called a bigeminal. This is a trigeminal PVC because we have 2 good ones and then 1 PVC. 2 normal, and then PVC, 2 normal and PVC. That's trigeminal. and the distorted QRS differently with the PVC, and obviously that this is the trigeminal unifocal, and it's not multifocal because all these three looks they came from the same ectopic foci because they resemble each other. They kind of similar, and they all three of them came from the same ectopic foci. All right, so
Sir,
yeah,
I have a
and
question.
yes, go ahead.
So, like in the study guide, you include the electrolyte imbalance and the AKG changes. Do we know how? Do we need to know like what are the patterns of the AKG for the for electrolyte imbalances or?
Oh, for electrolyte imbalance, it's just the potassium.
Okay,
In which that, yeah, potassium definitely you will find that a T wave, tall peak T wave, always
mm-hmm.
going to be hyperkalemia. Peak tall, and sometimes also with the wide QRS as well.
Yeah.
So peak
Yeah.
tall
Mm-hmm.
T wave, and the wide QRS. But if you just see it, peak tall T wave, that is um, evidence of hyperkalemia.
Okay.
Yeah.
How about
And, yeah, go ahead. Hmm.
hypokalemia? Do you need to know that?
Yeah. Yeah, hypogaly. I mean, there is a definitely the EKG changes, but we'll focus more on the electrolyte stuff and advanced EKG in next semester. So don't worry much about about these things because we are going to revisit this in more details and more advanced also level in adult health 3. Just
Okay.
for now, try to master the basic stuff,
Okay, got it.
the
Thank
one I
you.
just discussed earlier.
Mm-hmm.
And one of the slides I just missed, which is the map and the ejection fraction. Make sure that you at least know the what each formula entails and how you're going to apply. If you have like some numbers, how you're going to apply these numbers and plug it in the formula to find or to solve towards the. These can be like used like math questions, not I mean dosage, but at least these can be like math questions. If you have like systolic and diastolic, you're going to say systolic plus 2 diastolic and all that number divided by 3. So all the total of 1 systolic plus 2 diastolics, divide them by 3, that will be your MAP, the mean arterial pressure. For the ejection fraction, also the equation or the formula says that the stroke volume over the end diastolic volume, and that number multiplied by 10, by 100, that will be the ejection fraction because we know the ejection fraction is a percentage, which is supposed to be between 55 up to 70 or 75. So it's just to get some numbers and try, make sure that you kind of master the math formulas of MAP and ejection fraction. So let's take some time go over the question because I don't have the content to go over because you have the content and you have the recorded lectures. You can go over them and you go over the slides and all of that. So this will be like more of the application questions and how you're going to apply what you have learned from the content into clinical scenarios, and that will be the best way to kind of test your knowledge and to know how would you provide rationales for questions and so on. So let's see who is ready or able to read the first question. I need like, please, interaction, like some type of collaboration and participation, please. So the first question, you can
Um,
jump in and start the reading, please.
I could read it.
Go ahead.
So on our end is admitting a patient to the cardiac unit who has stable angina and a history of type 2 diabetes mellitus. The patient is scheduled for cardiac catheterization the next day. What medication would need to be withheld for 24 hours before the procedure and for 48 hours after the procedure?
So yeah, thank you. So I believe that we went over this question right in class, and we said that, and what because that was part of the diabetes mellitus, right? But now it's a cardiac. So it's kind of mixed cardiac and the endocrine system, in which that the answer, you all know that the answer is glucophage, right?
Yes,
So
metformin.
glucophage, which is metformin, should be withheld, we said 24 hours before and 48 hours after. So like a day, one whole day before the patient. So this applies to, let's just understand this conceptually and to understand this glucophage and the medications that are going to be detrimental or harmful to the kidneys. Anytime you are or any procedure or any type of diagnostic, testings in which that we are going to use a contrast media or a dye, which is we know that is detrimental or harmful to the kidney. We're not going to add another, stuff or medication or element that's going to destroy the kidney even more. So to cause like more dysfunction to the kidney. Metformin, glucophage, is going to do that. So that's why we're going to hold it because patient is going to or patient's kidneys are going to handle and take care of of the dye and contrast media. So so one day, 24 hours, all day before that procedure, try to hold glucophage to be withheld 24 hours before and about like 2 days after, 48 hours after cardiac catheterization. And this applies to, and again, when I explain about this cardiac catheterization, um, it's not just applicable to the cardiac cath. It can, if I replace the stem of the question with a patient undergoing, let's say like, brain or like, head CAT scan, for example, or a CT with contrast, right? Traumatic brain injury, patient, will undergo the CT with contrast, same thing, because there is a contrast. The point is that the key element is the contrast media or dye, regardless of that's a cardiac cath, that's a CT with like brain CT with contrast, or any type of like diagnostic test. But the bottom line here, and the keyword is the contrast media and kidney dysfunction. So don't add another element of this that would result in more dysfunction to the kidneys. That's the whole point. So the no, you can stop me anytime. Just you can just um, jump in and just ask the question anytime. Um, number two.
A clinic nurse is evaluating a patient who had coronary artery stenting through the right femoral artery a week previously and is taking metoprolol, clopidogrel, and aspirin. Which information reported by the patient is most important to report to the healthcare provider?
So the patient has a stent placed in the coronary arteries and the right femoral. Sorry. Yeah, and the coronary arteries that because that through the femoral because they for adults we usually use the femoral artery, and for the children we use the brachial, the arm, right, and the upper arm. So um, information reported by the patient is most important to report to the healthcare provider.
Is it A, or the first one?
So previous shortness of breath and fatigue. Um, right. Yes. Can you explain, Kareem, why?
Um, I went with that one just because shortness of breath is usually not good, and all the other answers seem pretty normal.
Okay. When adult health courses, I think these questions, some of the questions, or maybe the most, maybe, but you have to really go into deep and dive into the question and to different systems and find out about the answer. And that's where the providing rationale for these hotspot questions comes like to me an important aspect of to see how everyone is thinking and what's the process of thoughts they have you went through and how you came to the conclusion or to the answer. So for this specific question, when you look at analyze all of the four of them, you will find that the number one is most important, but sometimes you would get the point or get the answer, but the rationale is completely right, has nothing to do with the actual rationale. So for this specific one, said that your shortness of breath and fatigue because they may indicate anemia from the GI bleeding. Remember that patient on multiple anticoagulant medications, blood thinners. So think of blood thinners now, aspirin and clopidogrel. And we said after stent placement, patients will be on clopidogrel, Plavix, and aspirin for 6 months. And to be on these two anticoagulant blood thinners for 6 months, obviously it's a blood thinners, and patients sometimes will this may precipitate like bleeding. So patient may develop a covert like a GI bleeding, and the only way to get to know about it is through which sometimes some of the GI bleeding is not going to result in like massive bleeding. It's like microscopic bleeding, and you have to do like guaiac test to find out about the GI bleeding, the guaiac test, which is fecal occult blood test. Otherwise, there is no way you would know that patient is experiencing GI bleeding until you do, or at least until you do the CBC, and that will be and then the CBC will represent or reveal that there is a decline in HNH, hemoglobin, and hematocrit. So in this case, we have a shortness of breath and fatigue that is signs of anemia from the GI bleeding, because this patient on 2 anticoagulant medications. So, which is possible adverse effects of both aspirin and clopidogrel or Plavix. Now, the patient will need to continue with the medications on these meds, but may need treatment with PPI, proton pump inhibitors, right? Like Protonics, to decrease the risk of risk for GI bleeding. So the other findings will also be reported to the care provider, but will not require a change in the therapeutic plan for the patient. So the other 3 are going to be reported as well, but they are not going to result in change in the patient's plan of care. Make sense?
Yeah, that makes sense.
Okay, good. Perfect. Number 3.
Thank you.
Thanks.
Which topics will the nurse plan to include in a discharge teaching for a patient who has been admitted with heart failure? Select all that apply. So patient with a heart failure, you want to monitor and record their daily weight.
Okay, good.
Importance of stopping. Symptoms of worsening heart failure.
Yeah.
Okay, so sodium, how to read food labels for sodium content.
That's important too, right? 5.
Um,
And appointments too, right? To follow up with appointments. So to avoid rehospitalization, topics that should be included, which, as you had said, number 1, 3, 5, and 6, that should be included when discharging a patient with CHF, how to maintain sodium level, sodium diet, low sodium diet, the purpose and common side effects of medications like ACE inhibitors and beta blockers, what to do if symptoms are, like worsening, the CHF when it occurs, and the schedule to be, follow up with the schedule, the plan of care and appointments. And also the nurse will teach the patient that a moderate exercise or moderate increase in the heart rate and respiratory rate or effort is normal. So it's okay if they can tolerate the increase in the effort in terms of like walking or exercise or ambulation or exercise, that is, or any type of activity, that's good. So, but not to be the point that patient cannot, won't be able to tolerate that. So antibiotics should not be included in the treatment regimen of the CHF. Should not be part of the CHF, the antibiotic. Number 4.
The nurse is reviewing the laboratory results for a patient with an elevated cholesterol level who is taking atorvastatin. Which result is most important to discuss with the healthcare provider?
So
is it the LDL?
The LDL 170, right? Yeah. And I think we went over this in class, right? One of the questions we discussed in class was this one, I believe.
Yeah, it was in a
I
study
think
case
so.
too.
Right. Yeah, yeah, yeah. Yeah, the patient's LDL continues to be elevated and indicates a need for further assessment. Right. So let's do number 5.
Which finding in the patient with aortic stenosis will be the most important for the nurse to report to the healthcare provider?
Yeah, so some of these questions, if we haven't like went over specifically, like we went over this specific content in class, not necessarily that this is not something irrelevant or maybe it's, like shouldn't be like part of the review or exam review. I include some of these questions to go over the concept of how would you answer these type of questions, and it's cardiovascular, still it's within the same system. So the questions about aortic stenosis and in adult L3, we're going to cover the cardiac valve dysfunctions, the valve dysfunctions of the heart, like mitral valve stenosis, mitral valve regurgitation, aortic valve, stenosis and regurgitation, the same thing. So that will be covered more in kind of depth and more comprehensively in an intensive review or coverage in adult L3. So which finding in patients with aortic stenosis will be most important for the necessary for the PCP?
The temperature.
Why?
Because it's 102, it could indicate an infection.
Right. So when we look at aortic stenosis, we think of endocarditis, which is an infection within the heart. So the endocarditis is a concern with valve disorder or disease, and the elevated temperature that's definitely um, indicates there is a need that we have to follow up and do more of the assessment or diagnostic testing should be done, like echo, for example, blood culture has to be done to find out what's going on and to confirm or to rule out, maybe to rule out endocarditis. So the systolic murmur, decreased pulse pressure, and weak pulse, um, all of these symptoms are expected when we cover the content in aortic stenosis. You will find that all of these symptoms and manifestations that are expected in a patient with aortic stenosis. These are like expected manifestations of the disease itself and would not indicate an immediate need for further evaluation or treatment. So these type of questions, when you look at them, the answer is always going to be the symptom or the manifestation that is not expected, won't be anticipated from the disease process or as the normal or expected manifestation of the disease itself. Temperature elevation, it's not part of the disease process. Aortic stenosis, we know that 2, 3, and 4 all would be definitive manifestations that would occur with any patient with aortic stenosis, but not the elevated temperature. So that's why the spike in temp is going to be the answer, and which will indicate also that we have to follow up or maybe go further to find out with echo and blood cultures what's going on, if there is any infection, especially what's called the endocarditis. Number 6.
A patient who has just arrived in the emergency department reports substernal and left arm discomfort that has been going on for about 3 hours. Which laboratory test will be most useful in determining whether the nurse should anticipate implementing the acute coronary syndrome standard protocol?
And also we have a similar question, if not the same one, also in the study review guide or in the case studies one. We said it's always troponin level, right? So the cardiac troponin levels are elevated 3 hours after the onset of acute MI and are very specific to the cardiac muscle injury or infarction. So creatine kinase MB or CKMB and myoglobin levels, they will increase with acute MI, but CKMB levels, it will take about 6 hours to increase, and myoglobin very, I would say, non-specific. So the C-reactive, remember that the C-reactive protein, I think I wrote on like on the board, the CRP, C-reactive protein, and ESR, these two, whenever I see the ECRP, C-reactive protein, and the ESR, these two enzymes, they're always going to be elevated in any type of inflammation. That will be part of any inflammatory process or inflammation, and they are non-specific, they are non-diagnostic, or they are non-specific to any symptom, to any disease or any system. So automatically are going to eliminate number 4, and ESR of that was number 5, and then you will look at the three enzymes, C-reactive CKMB, troponin, and myoglobin. CKMB myoglobin, they are also they are going to be elevated cardiac and acute MI, but they are not specific to the myocardial tissue and the heart as troponin. Number 7. Any volunteers?
When the nurse is monitoring 53-year patient who is undergoing a treadmill stress test, which finding will require the most immediate action?
Which is a good question that will provide an explanation and rationale for why the PVC, or at least the running PVC, and the multiple PVCs are life-threatening type of dysrhythmia, or closer to be like closer to. It's very dangerous. It's very critical. It has to be treated immediately. And if so the PVC, isolated PVC, like every, let's say, like 5 minutes, 10 minutes, like an hour or 2 hours, you see one PVC, that's okay. But when you see the 3 PVCs in a row, that is not good. So the 3 PVCs in a row, that indicate the non-sustained VTach. It's kind of because the 3 or 4 the 3 PVCs in a row, that's going to it indicates that there's it's like a precursor to a more complicated, a more detrimental, and more life-threatening dysrhythmia is going to happen. So it's like it's a precursor to a major problem. So it indicates the non-sustained VTach and are an indication to stop the testing to avoid the worsening of any worsening of the dysrhythmia or any life-threatening dysrhythmia. So we have to stop the test when you see multiple PVCs. Could be 3 or 4 or 5 or even 2, like trigeminal, not good. So all this kind of like multiple PVCs, you can put it like this way: multiple PVCs, more than one episodic, like one runs of 5 minutes, but this is like you see consistently running multiple PVCs are running. That is an indication of non-sustained ventricular tachycardia. So we have to stop the testing to avoid any worsening of the life-threatening dysrhythmia. However, that the moderate elevation of the blood pressure and the heart rate and slight decrease in oxygen saturation, they're all normal or expected responses to the exercise and are expected during the stress testing as well. So during exercise, our heart rate will rise, our blood pressure also will rise, the oxygen saturation will decline because we are using too much oxygen, especially the heart, the cardiac muscle. So that is expected with any exercise and with any activity, especially with stress testing. Next question.
The healthcare provider prescribes 3 actions for a patient who was admitted with acute substernal chest pain. Which actions are appropriate to assign to an experienced LPN, LVN who is working in the emergency department? Select all that apply. One is correct. Four
Okay, good.
and six.
Right. So attaching the cardiac monitor leads, obtaining the EKG, and administering the oral medications are within the scope of practice of the LPNs. So the experienced LPN will be familiar with these activities, although the anticoagulant and the narcotics may be administered by the LPN to stable patients. Like if the patient is a stable condition, they can do that. But these are high alert medications that should be given by the RN to this unstable patient. So just because the patient is unstable, that should be given by the RN. So the medical history also requires an RN level education. So and that's within the scope of practice of the RN, which is the obtaining the pertinent medical history. And we always say that the assessment, obtaining medical history assessment, and patient teaching should always be done by the RN. 10.
The nurse makes a home visit to evaluate hypertensive patient who has been taking enalapril. Which finding is most important to report to the healthcare provider? The patient reports frequent dry cough.
Because that's a side effect, right? Because so a persistent and irritating cough, which is more of what is called accumulation of bradykinin, and patients usually develop the persistent dry, especially nighttime cough. That is a possible adverse effect of the ACE inhibitors and like enalapril, and that is the common common reason for changing to another medication. Like you can switch them to an ACE. I'm sorry, to the angiotensin 2 receptor, the ARBs, angiotensin 2 receptor antagonists or blockers. The other assessment data, they indicate a need for more patient teaching and ongoing monitoring, but would not require a change in patient's medical therapy or plan of care. 12.
Which patient is best for the coronary care charge nurse to assign to a float RN who has come for the day from the general medical surgical unit? Patient requiring discharge teaching patient.
Like patient general, it's not. So for this nurse who are coming from the general mid-surg unit, and patient hasn't been like experienced or working with or experienced to work with a high acuity or cardiac cases or right or
So it
cardiac
will be two, number
right
two.
right. So the RN who works on a mid-surg unit would be familiar with the heart failure and administration of the IV medications and ongoing monitoring for the adverse effects of Lasix or furosemide. The other patients need to be cared for by the RN who are more familiar with the care of patients who have acute coronary syndrome, like acute MI and sleeping angina, because they have experience to take care of these patients, like patients for post angioplasty, for example, patients post cardiac stenting that requires more advanced preparation and more experience and expertise. But number two, anyone from the mid-surgery, from any mid-surgery unit can do it.
I'm sorry, what was the answer?
2.
Thank you.
Yeah, number 2 with the Lasix, furosemide, anyone or any no grad nurse, right? A no grad nurse in the mid-surgery unit that easily can take care of number 2. But number 1, 3, and 4, they require more expertise, more experience, more preparation, and more maybe orientation to take care of a patient with high acuity, especially with the cardiovascular or cardiac events like acute coronary syndrome, acute MI, or unstable angina. But number two is basically it's just 3,6-furosemide IV for CHF. Okay, 13.
At 9 p.m., the nurse admits a 63-year-old patient with diagnosis of acute myocardial infarction. Which finding is most important to communicate to healthcare provider who is considering the use of fibrinolytic therapy with tissue plasminogen activator or altiplase for the patient?
Okay, so number 13, what was the answer?
Is it 4?
Yeah, I would guess 4 too.
Because I feel like the chest pain has been going on for like how many hours already?
So number 4, yes, but what was your rationale, Razia?
Oh, so like the pain has been going on for a long time already. For how many hours?
So to conceptually understand the time frame of the ultimate use or the best plan for using the TPA for acute MI, what your time frame, like patients who have been experiencing or had the onset of chest pain, for how long when you in which that you'll be able to give the this medication, that TPA medication.
You said
It should
6
be within
hours.
6 hours. We still can give it within 12 hours. In terms of administering the drug, you have 12 hours to give it. However, the best outcome would be within the first 6 hours. So, because the continuous chest pain lasting for more than 12 hours indicates that reversible myocardial injury that has progressed to the irreversible myocardial necrosis. Because after 12 hours, there is necrosis that would take place. So the fibrinolytic medications or drugs, like which is a TPA in this case, that are usually not recommended for patients with chest pain that has lasted for more than 12 hours. So don't use the 6 hours for administration of the drug. Patient had experienced the chest pain, the onset as 8 a.m. Right now, you have until 8 p.m. the same day to give the drug. It's not 6 hours in terms of administration, it's 12 hours. But the best results would be when it's given within the first 6 hours. So the other medications are also important to communicate, but would not impact the decision about TPA use. So the time frame, which is number 4, 14.
Wait, Professor, so the answer was 4, right?
Right, yes. And number 14 is
The nurse is caring for a patient who has heart failure and a new prescription of sacubitril valsartan. Which patient information is most important to discuss with the healthcare provider before administration of the medication?
So we have patient on angiotensin receptor blocker, which is sacubitril valsartan. They will increase because these medications are going to put the patient at risk for the angioedema for patients who are also taking another ACE inhibitor. So patients on valsartan should not be taking another medications. They're going to put them on to develop what is called the angioedema and dry cough or angioedema, especially for angioedema here with the bradykinin release. So patients on that specific angiotensin receptor blocker with neprilysin blocker, which is a combination, which is this medication, sacubitril, valsartan. This medication is a combination of two meds. The first one, which is sacubitril, which is a angiotensin receptor blocker. The valsartan is an angiotensin blocker, and then the sacubitril, which is the neprilysin blocker. Anyways, but these combination of drugs, especially valsartan, just focus on the valsartan, which is an ARB medications, ARBs, angiotensin receptor antagonists or blockers, should not be taken with another ACE because we know that these ARBs, they can release the bradykinin and cause angioedema. The patient on these meds supposed not to be taking another medication that's going to result in like ACE inhibitors, for example. So for this specific question, it says that here, which patient information is most important to discuss with a PCP?
Is it 2?
So,
Two, yeah.
Right. So because the lisinopril is an ACE, so because the ARBs that are going to increase the risk of angioedema in patients who are already taken or on the ACE inhibitors. So the resultant effect would be that it may, if a patient develops angioedema, that's sometimes really life-threatening and result in what is called the airway obstruction, and that especially with the tongue enlargement and swollen tongue sometimes and larynx result in the obstruction of the airway and results in sometimes it's very life-threatening. So the what will be the other risk factor other than the angioedema from the ARBs and ACE inhibitors combination of these two things together? So first one is angioedema. That's detrimental. That's very life-threatening because angioedema. What else would be another side effect, like the risk for other adverse effects, such as what? That are going to be increased when you combine these two meds together at the same time for this patient, other than angioedema. So angioedema number one. Two more.
Would it be potassium?
Yes. Hypo or hyperkalemia?
Hypokalemia.
Hyper, right? Elevated potassium level, and also you can add the decline in blood pressure. The hypotension also are going to be increased in terms of that patient will be hypotensive even more when you give them these two meds together. So what we can get from this question is that look at the mechanism of action of each drug or classification of drugs and find out the combination of the first one and the expected one. In other words, that we know this valsartan, it's an ARB, and that's going to result in hyperkalemia, angioedema, and hypotension. So the answer should be something that consistent with these three key elements, which is the ACE inhibitor, which is the same thing. ACE inhibitor is also lisinopril. Lisinopril is going to result in hyperkalemia, hypotension, and angioedema as well. Okay, next question.
The nurse is working with an experienced assistive personnel, and an LPN LVN on the telemetry unit. A patient who had an acute myocardial infarction 3 days ago has been reporting fatigue and chest discomfort when ambulating. Which nursing activity included in the care plan is best assigned to the LPN? Just taking the vitals too.
For for 16. What made you think, Rose, that number 2 is the correct answer? Because I think we have to have them some type of dialogue and discussion to make sure that you're
Yes.
you know
Because
yeah, okay.
well, it could have been 1 or 2 because I know LPNs are allowed to administer medication, but maybe not particularly nitroglycerin. Vital signs are obviously could be given to LPNs or your patient tax. But
Okay.
teaching is the responsibility of an RN. So the teaching and explaining 3 and 4 are pretty much education.
Right, perfect. So you're in between because of the teaching and assessment, you're in between 1 and 2, right?
Yes, but then
Perfect. Yeah, that's excellent. That's great. So what's the difference between 1 and 2? 1, administered nitro, sublingual, if chest pain occurs. Number 2, vital signs before and after patient ambulation.
Professor,
Yes.
is it because the client has MI, so you say is an unstable patient?
Okay. It's unstable if the patient had developed the MI today. In 2-3 days from now, patient's not considered to be unstable. Unstable, the onset of the acute MI within the 24 hours. Yes, it is unstable. Patient has experienced the acute MI within 24 hours. That is unstable. But in 2 or 3 days later, like after, like post the onset, then patient is no longer is going to be classified as or identified as unstable, which makes number 1 to be the correct answer, right? Because this said here 3 days ago, right? So the administration of nitro and appropriate patient monitoring for therapeutic and adverse effects are included within the LPN education and school practice. So taking blood pressure, pulse, and oxygen saturation should be delegated to the who? Who would be taking that? Number 2.
The
Yeah,
CNA.
exactly. Right?
Mm.
Yeah. So they can give the nitro 0.4, and it's not something that if we're like nitro IV, you know, I might say that it should not be given by the LPN, but in general, that it is a nitro sublingual, and also the patient is considered to be like sort of unstable, to be stable now 3 days after the onset. So the teaching, we know that. So we had already eliminated number 3 and 4, but one were between number 1 and 2. Always remember that the education assessment and education, both things, are within the scope of RN. So that's why we end up with 1 and 2, and then we said that 2 should be done, can be performed by the assisted personnel, a CNA, and then we can the answer is going to be number 1. Any question about this one?
No.
Okay, good. 17, please.
The emergency department nurse is caring for a patient who has been admitted with left anterior chest pain, suggesting possible acute myocardial infarction. Which action will the nurse take first? Is it the draw the blood for the troponin measurement?
Okay, you said to draw blood for troponin I, right?
Yeah.
So what would do that? What about the patient? If you have noticed or maybe witnessed or maybe heard of that, patients once they are um, present in the ER, once they complain of chest pain, they're going to be escorted the number one like triage nurse without even asking the triage nurse to look at the patient. They will escort the patient right into that examination room and do few things. The first thing they're going to do is that with the chest pain, you have to treat that. So priority for a patient with unstable angina and or acute MI, because at this point we don't know if the patient has like stable angina, unstable angina, acute MI. For us in the ED in the emergency department, patient has been presented with chest pain. We have to rule out the ACS, the unstable angina, or the acute MI. To rule out that, it requires they have to do the EKG, 12-lead EKG, 12-lead EKG, and then we have to do blood work like for cardiac enzymes, special troponin I, troponin levels. Now, before we do all of this, we have to stabilize or at least to manage patients' chest pain. So it is important to remember that to assess vital signs before administering the sublingual nitroglycerin. So the priority for this patient first is to manage patient's pain experience now. So we have to do a administer sublingual nitro because that's going to alleviate, if that's the angina, is going to alleviate patient's chest pain. So we have to do the sublingual nitro before we do anything else.
Makes sense.
Right? All right, good. 17, always
Excuse
start
me,
with.
Professor.
Sure.
These questions are confusing
Mm-hmm.
because most of the time, like they said, the EMS already gives it to them before they come. And you would they have said that they have?
Yeah. Okay.
It has taken it 3 times.
No,
We
no,
don't
no,
know
no.
how many times
It's
they've taken it.
okay. All right. Okay. Good point. So the stem of the question here, these are the case studies that are isolated from any other scenarios. There is no assumptions. There is no comparison to other scenarios, like in the clinical, like stories. There is no, because we know, especially those who are working in the healthcare system, sometimes they are very confused with what's going on in the field and what they have been practicing physically, like, personally with patients or been witnessing others are doing with patients and trying to apply it to the questions in the exams. Try my advice to any, all those people who are working in the healthcare system, try not to mimic or to bring all these kind of experiences and apply it to the questions. Sometimes you fall in a little trap that, will result in answering the questions incorrectly because for two things, very, very quick. Sometimes what's being practiced is not within the I would say the scope or within the recommended practice or recommended evidence-based practice. And second is that the what's being practiced is not consistent with the recommendations of, let's say, ACLS or with the healthcare system or our protocols or so. For many reasons, I don't think it's a good idea that are going to bring. It's always I would say the point here is that we try our best to apply what we have learned in clinical, right, and put it into kind of perspective when we answer the questions. But unfortunately, sometimes when we bring stuff from clinical, especially not from clinical like placement as clinical rotation, but more when you are working physically, like you are employed as a healthcare provider like EMT or LPN or CNA or in the healthcare system and trying to bring that to the class. Sometimes it's not a perfect fit, and because sometimes the nurses they have their own shortcuts, and when you look what they have done and performed on the clinical side as a shortcut and you compare it to the question and try to apply it to these questions, Sometimes that will result in incorrect answers. And my advice is to be careful when you apply these kind of scenarios into the exams. So one more thing about this is that as you look at the question, or as you read it, as you look at the whole scenario for this question and other questions, try to isolate it as much as you can from adding more stuff. Do not assume or predict or anticipate. Things are okay. We know that patient already had taken 3 tablets sublingual, and then patient the medication. Remember, it did not say here that they have been scored by the EMTs, right? It suggests a nurse is working with an experienced, um, sorry, yeah. So the emergency department nurse is caring for a patient who was just admitted. So it did not say that a patient came with family, came with EMT, or through with the ambulance, or came with the EMT. We don't have the context of the whole thing. We didn't have the context of the whole scenario. All we have, what we can deduce or we can get from the stem, is a patient complaining of chest pain. Regardless of patient has taken 1 or 2 or 3, we don't know. We don't have no clue. It did. So my advice is try not to add any layers of content or to expand on the stem of the question, or add more things that are known as maybe normative to everyone in healthcare systems, that okay, the patient has already taken 3 within the last 15 minutes. Chest pain hasn't pain persists, and then the patient was escorted or brought to the hospital. It's not always the case. Maybe the patient just stopped by himself or herself to the emergency department. Maybe the family just escorted the patient without giving the patient any sublingual tablet. We don't know, so we have no clue about what exactly had happened with this patient. So this is a major advice to, when you answer these questions, try your best not to add any content and layers of content to the question, and leave the stem of the question as a skeleton, not adding any flesh or any bone. Any flesh or any meat to it. Joy, did you get anything of this? Does it make sense? Joy, do you hear me? Can you hear me?
Yes, Professor, I got you. Thank you.
You see, yeah. So try not to add. I know that we say always we anticipate, we predict, we try to isolate the question as much as you can. It's not always the case, but these kind of scenarios, do not add other stuff to it. Okay, number 19.
The nurse has given morphine sulfate 4 mg IV to a patient who is having an acute myocardial infarction. When evaluating the patient's response 5 minutes after giving the medication, which finding indicates a need for immediate further action?
Yeah, I think we answered this also question in class, right?
Professor, are you still there?
Yes. Yeah. I can hear you, everyone. Yeah, but I think everyone said. I just said that we already, I think, answered this question. I believe the same or similar one in class. That when we give morphine sulfate, we anticipate that patient's pain level supposed to subside completely, right? Supposed to completely subside to the 0 level.
So it will be 4 then?
Right, exactly. So the goal of pain management for the patient with acute MI is to completely eliminate the pain because the ongoing pain indicate cardiac ischemia. Even level 1 with chest pain with the patients with angina or acute MI, that still indicates the cardiac ischemia. So even being, pain rated at a level of 1 out of 10 should be treated with additional morphine sulfate, although possibly at lower dosage. The other data indicate a need for ongoing assessment for the possible adverse effects of hypotension, respiratory distress or depression, and tachycardia, but do not require further action at this time. So yeah, the answer was number 4. 20.
The nurse is preparing to implement teaching about a heart healthy diet and activity levels for a patient who has had a myocardial infarction and the patient's spouse. The patient says, I don't see why I need any teaching. I don't think I need to change anything right now. Which response is most appropriate? Is it the second one?
Right. Can I give a rationale why 2 is correct answer?
I think it's just to understand why the patient is saying that. It's like you're not brushing away their feeling, but you just want to understand better and help them.
Right. Yeah. So yeah. Right. So this response acknowledge the patient's statements and would ask for further clarification. Right. So for behavioral or behavioral changes or to change the behavior, the patient must be aware of the need to make changes. So this response would acknowledge the patient's statement and ask for further clarification. And would give also the nurse more information about the patient's feelings, about patient's diet and activity levels, and may increase the willingness to learn. We look at the other responses, even though they might be accurate, it may indicate an intention to teach whether the patient is ready or not and are not likely to lead to changes in lifestyle. So our point here is that we're trying to get to the patients we would acknowledge the patient's statement and also would like to encourage for further clarification. And also at the same time, we try to, our statement should lead to changes in patient's lifestyle. 21. Yeah, 21 actually it's a classic question that we have, we answered too many maybe in the pathoform and even mid-surge about spironolactone, which is the potassium-sparing diuretic. So the answer is going to be the potassium level, and hyperkalemia is a common adverse effect, both ARBs and ACE inhibitors. And I think we went over this also in previous questions as well. 22.
The healthcare provider telephones the nurse with new prescriptions for a patient with angina who is already taking aspirin. Which medication is most important to clarify further with the healthcare provider? Aspirin and would it be 1 because they are both anticoagulants?
Anticoagulant will be It's correct, but we can have multiple answers here actually for this question. It will be the clopidogrel 75 and one more medication.
That's it.
Nitroglycerin.
The NSAID, right?
Oh,
The
yeah.
ibuprofen every 4 hours as needed. The NSAIDs like ibuprofen, they inhibit the beneficial effect of aspirin. So again, the stem has to be like within the context of like post cardiac stenting. Usually we put patients on aspirin and clopidogrel. That's okay for 6 months, sometimes even for a whole year. So, but the stem has to be like more, kind of adjusted or like, modified to get to the point. So you thought of aspirin and clopidogrel because of blood thinners and bleeding and so forth, right? Now, for this question, it's about the NSAIDs, effect of the NSAIDs that they inhibit the beneficial effect of the aspirin in coronary artery disease, in CAD. So the current American Heart Association guidelines, they recommend the against the use of other NSAIDs for patients with cardiovascular disease. So patients with cardiovascular disease, they say, they're saying is that what they are trying to say here is that the NSAIDs, they inhibit the effect, which is the beneficial effect of the aspirin in CAD patients or patients with CAD. So the clopidogrel, metoprolol, topical nitroglycerin, which is like the nitropase, they're all appropriate medications for patients with coronary artery disease, but should be verified because the prescriptions were received by telephone. Anyways, so the question here, if you want to exclude clopidogrel for a minute here, the ibuprofen is the most important one, because remember that patients, because the question that we have answered about the post stenting, like remember that patient post stent placement and patient was on aspirin and clopidogrel, patient may have developed a GI bleeding. So that was a different scenario. It was about the GI bleeding. This question, you can combine aspirin and clopidogrel and Plavix. And we said that post-stenting patient can be on these two medications, aspirin and clopidogrel, 75 milligrams for 6 months, minimum 6 months. So it's not an issue here. It's not about the clopidogrel. It's more about the ibuprofen as an NSAID that is going to inhibit the beneficial effect of the coronary artery disease, the effect of aspirin in coronary artery disease patients. 23.
At 10 a.m., a hospitalized patient received a new order for esophageal echocardiography as soon as possible. Which action would the nurse take first?
Remember that there are two different types of echocardiography are done. The traditional classic one is called the echocardiography, which is the transducer is going to be placed on the chest, and that's the classic old traditional one. And the newest method, which is the invasive through the mouth endoscopy. It's the transducer introduced through the mouth into the esophagus, and the transducer will be placed to the end of the esophagus next to the heart. So it is called transesophageal echocardiography. That's TEE. This is very new, like one of the fairly new methodology called TEE. It's an echo, but it's an invasive procedure. So which action will the nurse take first?
NPO status.
Okay, yeah, exactly. So because TEE is performed after because usually they numb the throat, they anesthetize the throat with like lidocaine or lidocaine spray, and so the throat is numbed using topical anesthetic like lidocaine, and with the use also of IV sedation, like propofol, IV or Versed, or so it is important that the patient be placed on be NPO. So the patient should be placed on NPO status for several hours before the test, because we are going to introduce the TEE, the endoscope, that's endoscopy. Patient throat will be numbed with a lidocaine or like topical anesthetic agent with the use of IV sedation, like conscious sedation, like a propofol or Versed. 25.
The nurse assesses a patient who has just returned to the recovery area after undergoing coronary arteriography. Which information is most concerned?
Return so recovery area, so the PACU after the arteriography. And in this case, and also within this procedure, patient had already received a large amount of contrast media. But this question, it's pertinent to something else, right? So it's not about the contrast media here. Given all the four answers, I mean, we have blood pressure, that is 154/78, pulse or pedal pulses, palpable, +1, left groin. So remember that in adults, whenever you hear about coronary arteriography, obviously, we know that 99% of the cases that we use for adults, we use the groin area for the femoral access to get to the coronary arteries. So the catheter will be introduced from the groin, like from the femoral artery. So in the groin. So most concern, which information? In other words, that post arteriography or cardiac catheterization, in other words, the catheter will be introduced, and the removal of the catheter, patient will be, now patients, this is post-op, like after the procedure has been performed. Patients in the PACU in the recovery area, and we're going to place like pressure on the area and make sure there is no bleeding. So which of the following, in other words, which of the following manifestations an indication or reflects or reveals a type of bleeding that patient has hemorrhage?
3.
No, bruised area is fine. That 3 centimeters bruised, the bruise is not consistent with the bruised area. The bruised area is like the bluish, kind of red bluish area. That's from the like traumatized artery.
The
That's
artery, right?
expected. What about the
Is it
heart
number
rate?
4? Number
Yeah.
4, because it's
When the
over
patient
100.
bleeds, right? Exactly. When the patient bleeds or the hemorrhage results in hypotension and tachycardia. Hypotension and tachycardia. So the most common complication after coronary arteriography or catheterization is hemorrhage. And the earliest indication is hemorrhage and increase in heart rate. The other data may indicate a need for ongoing assessment, but the increase in heart rate is the most of concern because that's an indication of hemorrhage. So always hemorrhage, tachycardia, hypotension. 28.
The nurse is monitoring the cardiac readings of patients in the coronary care unit. Which patient will need immediate intervention?
So patient with AFib, heart rate 88, patient with a newly implanted demand V pacemaker who has occasional period of sinus rhythm 90, or patient has acute MI and sinus rhythm, heart rate 76, with frequent PVCs. Multiple PVCs. Or patient on beta blockers who has a first degree AV block, heart rate 58. So which one is more of a concern to you when it comes to all these 4 patients, and one of them has multiple PVCs, frequent PVCs?
Is it 3?
Yeah, remember that question when I explained about the 3 or more premature ventricular contractions, 3 or more PVCs occurring in the setting of acute myocardial injury or infarction can lead to ventricular tachycardia, VTAC or VFib. 3 or more PVCs can lead to or result in VTAC or VFib, which, in other words, it's like cardiac arrest. When you say VFib, ventricular fibrillation, it's like cardiac arrest. So the rapid treatment is necessary for this patient. The other patients also have dysrhythmias that will require further assessment, but there are these cases or scenarios are not as immediately life-threatening as the patient with the multiple or frequent PVCs in the setting of acute MI. 30.
2 weeks ago, a patient with heart failure received a new prescription for carvedilol 12.5 milligrams orally, which finding by the nurse who was validating the patient in the cardiology clinic is of most concern. Would it be 3?
Why?
Because it's a beta blocker and it can cause bronchospasm.
Mm-hmm. Yeah. So silence bradycardia at a rate of 48. Yeah. So research indicate that mortality is decreased when patients with heart failure use beta blockers, such as carvedilol, which is correct in this case. So when the beta blockers is started for patients with heart failure, the heart failure symptoms may initially become worse for a few weeks. So increased fatigue, activity intolerance, weight gain, and edema are not indicative of a need for, they are not indication to discontinue the drug at this time. So the heart rate of 48 indicates a need to decrease the correct or the carvedilol dose. That's the only answer or indication to decrease the dosage, which is the bradycardia, 48. And this question also applied to different scenarios. A patient who is like hyperthyroidism on propranolol, and patient's heart rate drops to like 52. So that would be similar scenarios. It's always think of beta blockers, and then beta blockers, they lower the blood pressure and also they lower the heart rate as well. So 48, that's a major concern for this patient while on carvedilol. Rachel?
Professor, I have a question.
Yes.
So you said if they take beta blocker and it's gonna worsen the symptoms, for how many weeks did you say?
For how? I'm sorry, what you said. So I'm sorry, what's one more time your question, Trizia?
Okay, so like you mentioned that if they take this medication,
Mhm.
like the 1, 2, and 4 options are like the symptoms that are gonna worse for a few weeks, but like do you have like a specific week of how, like specific week?
No, actually, there's no specific time frame, but at least it says that the symptoms may initially become worse for a few weeks. So the increased fatigue, the activity intolerance, the weight gain, and edema are not indicative of a need to discontinue the drug at this time. So, however, that it may result because that applicable to even all blood pressure medications. Patients, when they start first begin taking the antihypertensive medications, most of them, that especially the beta blockers, going to result in like headedness and headache, and that sometimes patients will stop taking the meds because of that. So we have to teach them that these symptoms are not permanent. They are irreversible in terms of that the patient may experience these symptoms for a few weeks. Sometimes we go between like 4 and 6 weeks. It's very I would say individualized to among patients. Some patients within 2 weeks resolves. Some patients within 3 weeks resolve. So, in other words, that these symptoms that are not specific and permanent, I mean specific to all patients at the same time frame. It's very individualized. So at least just to warn them of these symptoms that they will happen in the future and they are not permanent and they are going to resolve by itself, over time. But the most serious symptom was the bradycardia for that patient.
Okay, thank you, Professor.
Yeah. 32, please.
The charge nurse in a long-term care facility that employs RNs, LPNs, LVNs, and assistant personnel has developed a plan for ongoing assessment of all residents with diagnosis of heart failure. Which activity included in the plan is most appropriate to assign to the LPN, LVN team member? 2. 3 and 4 are for the RNs, and then 1 is going to be for the CNA.
Excellent. Yes. Yeah, that's just like exactly typical to the question that we covered previously. Yes. Yeah, and in previous questions. Yes. Good. 33. Other volunteers, please.
The nurse is participating as a team member in the resuscitation of a patient who has experienced a cardiac arrest. The healthcare provider who is directing the resuscitation asks the nurse to administer epinephrine 1 milligram IV. After giving the medication, which action should the nurse take next? State epinephrine 1 milligram IV has been given.
Rationale.
I don't know, Professor, I'm just applying the scenario that I see when they call a code and what they do.
Good. Yeah. It's good. That's a good application because the American Heart Association, they recommend what is called the closed loop communication between the team members who are involved in the code and the resuscitation of a patient. So the other actions may also be needed, but the initial action after administering the medication is to ensure that the team leader knows that the prescribed medication has been administered. And we are going to learn more about this kind of application and apply more of these concepts pertinent to this, what is called the MUC code. We're going to have that as our simulation for adult L3. So it's kind of talks to and applies the communication skills within the code when it's been implemented. 34.
During a home visit to an 88-year-old patient who is taking digoxin 0.25 milligrams a day to treat heart failure and atrial fibrillation, the nurse obtains this assessment information. Which finding is most important to communicate to the healthcare provider? Would it be 3?
Excellent. Yes. And I think I went over this, several times right in class about the dish toxicity, the manifestation of the digoxin toxicity, and number 3 is correct answer. Yes, 3.
Yeah.
Not 39.
The clinic nurse obtains the information about the patient who is taking warfarin after having a deep vein thrombosis. Which finding is the most indicative of a need of change in therapy?
Yeah. See, this type of question, it's not even, I'm not trying to say that, we don't apply other stuff or content from other areas or systems or even from clinical to the scenario. But for this question, the answers speak to itself. In other words, that you have to assume that patient, and actually it's not assumption here because it's given, is that patient on warfarin sodium anyways. So it's sometimes you will some of the questions you have to think kind of deep
It's gonna be
into the
thermal pressure.
question, but here no, it's given, right? It's warfarin sodium, so Coumadin. So patient on Coumadin, um, the most indicative of a need for change in therapy. In other words, that when would you adjust the dosage of the Coumadin and not to continue the same dosage for the next day? When
Is it 2?
right. What about number 3?
I think that's normal, right?
Exactly.
Yeah.
Yeah. So anticipated normal and anticipated with with the warfarin sodium patients to bleed or slightly have bruises and ecchymotic areas everywhere, or especially with the um, uh, uh, blood so I mean the sites where the blood is being drawn, that's normal. But the INR of 1.2 is very low, and we anticipate that therapeutic range is supposed to be between 2 to 3. So minimum 2.0 and not to exceed 3.0. So between 2 to 3. So this is less than 2. So we have to increase the dosage of warfarin and sodium for this patient to be within range 2 to 3. So the lower the number, the higher that drug dosage supposed to be. So less than 2, increase the dosage. Higher than 3 INR, lower the warfarin dosage.
Professor, I have a question about that last question.
Yes.
When you're taking warfarin, don't you also have to like avoid eating a lot of like leafy greens? Or no?
Well, when it's in moderation, that's fine. I mean, it's not something that they're going to eliminate completely from their diet. We
Yeah.
try our best is to encourage them or teach them too much of that stuff is not good. Too much, right? So eating that's fine. I mean, every day they eat for lunch, that's fine. But not like to eat like a whole lot of the morning, evening, and not all day eating all that green stuff. Too much of that green stuff is going to result in counteracting the effect of the but it's not, and also for this specific question, it's not something that are going to adjust the dosage because of that.
Okay.
They're going to adjust the dosage because of 1.2, but it depends on the scenario and how the question is being like phrased or presented. So patient reports eating a green salad for lunch every day. I don't think it's going to be something to adjust the dosage because of that, right?
Yeah, okay.
Right. Yeah.
Thank
We
you.
will educate them not to eat, too much consumption of green leafy vegetables. That's going to result in counteracting the drug effect, but in moderation, that's fine.
Okay, thank you.
Yeah. Mm-hmm. 41. Okay. 41. Volunteers.
During the initial post-operative assessment of a patient who has just been transferred to the post-euthanasia care, unit after a repair of abdominal aortic aneurysm. The nurse obtained this data, which finding has the most immediate implication for the patient care.
Yeah, so the aneurysm we haven't covered the aortic aneurysm, but aneurysm is the enlargement of the some part of the segment of the aorta that's going to be like very weak and fragile and easy to ruptures, and the increase in blood pressure, the elevated blood pressure is going to result in the eruption and the bursting and opening of that kind of rupture of the aneurysm, and that's going to be detrimental and be life-threatening. Sometimes leads to death. Patients may kind of may die from this because that results in massive internal bleeding from the from the aorta, and that results in massive bleeding. And sometimes most patients we are unable to save their lives. So with the surgical procedure or with any intervention, because that's a massive bleeding internally. So the rupture of the aortic aneurysm, that's life-threatening. So any elevated blood pressure for this specific scenario, aortic aneurysm. So, and again, the blood pressure control, it's a key element towards managing patients with aortic aneurysm and prevention of the rupture of the aneurysm. So number one is always the answer for aortic aneurysm, elevated blood pressure. 4 to 3, as you prepare to give the following medications, patients with multiple health problems and patient in the hospital with DVT. So which drug is most important to double check with another license? I think we went over this too, right? No? In class? No. Okay. So which medication is most important to double check with another RN?
Professor, is it warfarin?
Right. So the anticoagulant medication are high alert medications, and they require the special safeguards such as the double checking of medications by 2 nurses before administration.
Professor,
Yes.
you're not giving us aneurysm in the exam,
No.
right?
No, that was just a question. I forgot that we
Okay.
didn't cover it. Yeah. We did not cover
Okay.
that. Yeah. 44 patients, okay, seen the clinic with short breath, fatigue, evaluated for possible diagnosis of heart failure. Which lab result will be most useful to monitor? So number 2, BMP. BMP, as the troponin, always the correct answer for the confirmed diagnosis of acute MI. It's same thing here, is that similar scenario. BMP is always the correct lab result that's going to, or the lab monitoring system to rule out the diagnosis of heart failure. So the research indicates that BMP level increase in patients with poor left ventricular function and the symptomatic heart failure. They can be used to differentiate the heart failure. I think we went over this in class in terms of that patient who had developed the chest pain, if that's muscular or that's like pneumonia, versus like patients with chest pain from heart failure, dyspnea, and fatigue. That been experiencing these symptoms due to heart failure or from pneumonia. So we can differentiate between these two conditions if that's a pneumonia versus heart failure by BMP. BMP is always positive and elevated in patients with heart failure. And we said that BMP is supposed to be less than 100, and patients with acute or with decompensated heart failure, always it's over 100. That confirms the diagnosis. So 45 patient who is scheduled for the coronary arteriogram, which is cardiac cath, admitted to the hospital for that procedure. So which information is most important for the nurse to communicate to the PCP before the procedure? And we have our first question was very similar to the same concept for this one.
Yeah, you already said it, Professor.
Number 4, right? Number 4,
Yeah.
right? Number 4. Okay.
Professor, are you going to post this on Canvas for us?
Oh yeah, it's already
Okay.
on. It's already
Oh.
posted on Canvas. Already posted.
Okay.
Already
All
posted.
right.
So the last
Thank
question here, and I'm open. I'm ready to answer all your questions. If you have any questions. So after this, which is number 7, the last question at 47, the sequence or the answer to you have some time to live with this question. You really have to understand the rationale behind it. It's 4, then 2, then number 1, and last one is number 3. So 4, 2, 1, 3. This is the list of the order in terms of the hierarchy, or the order in terms of the patients who will be seen first, second, third, and fourth. So then patient number 4, look at patient number 4, has symptoms of an ischemic pain pattern and has at least 2 risk factors for acute MI: diabetes and obesity. Patient's temp of 38 degrees centigrade is an inflammatory reaction to acute MI or acute cardiac damage that could have occurred earlier in the week. He also he also had flu symptoms during the whole week. That's for number 4. Number 2 should be seen next. And patient's symptoms, her symptoms started within hours of eating, which could indicate the food poisoning. This is a question like comprehensive. It's beyond just the class or maybe exam number 2, but these type of questions we will get to work on understanding the rationale behind them, and we will have more of these similar to these questions in class as well. So the patient who may have been experiencing number 2, the food poisoning. She is febrile, she's tachycardiac, and here she has also lightheadedness that could have been a result of dehydration. Patient number 1. So we said number 4, then number 2, and then number 1. Number 1 is stable, and same patient number 3. So patient number 3, however, the 14-year-old is in pain, number 1, in pain, and should have an X-ray as soon as possible to rule out the fracture. So 4, 2, 1, and then 3. 48, I'm going to give you the answers because I have 5 minutes to leave. Yeah, about 5 minutes. And then I will, if you have any questions, right after that. So 48, because I think we covered most of the concepts in previous questions, similar to these things. To these questions. So now 48, the answer is 2, dry cough, 3, headache, and 5, hypotension, which is the ACE inhibitor as a potent vasoconstrictor in the blood, and the resultant effects are going to be like a constriction of blood vessels that will result in the following. So the answer was 2, 3, and 5. And then 49, patient, as you take care of a patient or client with a new prescription of digoxin, answer to this question is you teach the patient about dig or digoxin. Number 2, 4, and 6. So you are looking for the statements that require further teaching, further teaching, 2, 4, and 6. Digoxin is a cardiac glycoside that slows and strengthens the heart, providing more regular rhythm. So because digoxin has a narrow window or therapeutic window that require like every 2 weeks to monthly blood level monitoring initially. So in the beginning, you may start digoxin level, blood level done every like 2 weeks or monthly, but later on, this is initially, and then later on we can do it like every 3 or to 6 months. So it's usually helpful for a client to take digoxin at specific time early in the morning, each day to establish the blood level, like consistent blood level to be taken at the same time. This is exactly like 6 a.m. in the morning, 7 a.m. in the morning to be like consistent in a daily specific time every day. And we teach also the client to take the pulse before each dose of digoxin and to notify the PCP if the rate changes, especially like less than 60. And also we teach the patient about the other stuff like the report like increased fatigue or muscle weakness immediately to the PCP and signs of digitalis toxicity. We talk went over this in previous questions. Now, question number 50, a nurse places electrodes on a collapsed individual who was visiting a hospitalized family member. The monitor exhibits the following. And the first glance, you look at this, it's VTAC, right? So the rhythm experiencing a VTAC. Although that all the options listed here are appropriate for someone with a stable VTAC, it is not yet known whether the client is a VTAC, if the patient like with VTAC is stable or unstable or pulseless. So we have to find out if the patient has pulse, then they will have a different route or path for a treatment. If patient is pulseless VTAC, then patient will be treated as if patient is a VFib. So the nurse must first assess the airway, breathing, circulation, and level of consciousness to establish the client's stability. So we have to find out if the patient is stable or unstable. So the answer was 4, right? Okay, and 51. As you evaluate the cardiac function of client with a history of V hypertrophy on cardiac, which is a CCB, the answer is going to be 1, 3, and 4. 1, 3, and 4. So when you evaluate the cardiac function, assess for client's statements indicating normal client activities being completed completely or successfully in completion. So the positive activities include sleeping well even after traveling upstairs. Traveling or like going upstairs to the second, third level. The blood pressure within normal limits. Like completing activities of ADLs independent without any assistance. So it is good that the client is tolerant to the low-fat diet and has normal sodium potassium level, but that is not related to the adequate cardiac functioning. The pitting edema in the morning is a sign of cardiac compromise. So number 1, 3, blood pressure, and 4, the activities independent, like ADLs done independent. Now 52, This is a post-surgical after the FemPop bypass graft. And that's an area I would encourage that, go over this stuff for content and try to read about the post-op complications, how to assess for the graft occlusion, and what are the signs and manifestations of graft occlusions, very important topic, and how to intervene, and when would you intervene as a serious condition. So 52, the ranking for the actions should be number 5, assess peripheral pulses, and then assess incision site, number 3, go back and assess the lung fields, 4, number 2, assess pain and obtain medication for pain management, and then number 6, instruct client positioning, and last one is number 1, which is offer clear fluids. So these are in terms of ranking of the interventions or actions or nursing actions in terms of the priority post FemPop bypass graft. Okay, so I think this was the last question. So any questions before we stop the session?
Professor, how many EKGs will be on the exam? I remember you said it was 10 last time.
No,
You
will be
joking?
about 5.
Okay, good.
5. Yeah. 5,
Oh.
pure 5, but maybe like within other questions 2 or 3, but 5 will like pure. You have to identify normal sinus rhythm, sinus brady, sinus tachy, PVCs, PACs. These are just the most, I would say, for this adult health 2. In adult health 2, we'll get to the more advanced stuff. Other questions?
Professor, so in your study
Yeah.
guide, you included the PAD and the PVD, and based on your question, you didn't really give us any question about that. So
Yeah. Some of the content I wasn't able to be comprehensive today on the review, but I cover some of the important cardiovascular stuff. But again, it's not conclusive for all different topics that will be in the exam. Yeah. But go between the exam review, this one session, and then the study guide. Combine both of them together.
okay, so
Yeah.
so based on the review right now, so do we focus more on the heart failure and the MI?
No. All of them are important. All of them. So EKG and the CHF, PAD and PVD and DVTs and the acute MI and angina, all of that important, and all equally, I would say, important. But I can't be inclusive in terms of or in terms of equity, number of questions should be distributed over the different types of topics. I couldn't cover all the topics with and with these questions. It's just I try to explain sometimes when I explain about one question, it's more conceptual application to other topics, not specific to this one. Just
Okay, Professor.
study exam strategies towards solving exam questions.
Okay, Professor. And on one last question, so in your review slides, there's an antidystrythmic drugs. Do we need to know all of this, or do you have a specific drugs that we need to
Antidystrythmic drugs?
Yeah, there's a lot in here.